It's a great pleasure to be here today and have a discussion about clinical challenges in thrombosis. This is the second session that we're doing, and we have a great panel today to entertain and moderate these different clinical scenarios that we'll be going through. So without further ado, I'll pass things along so that we can go through the introductory slides with Dr. Siraj Mitawani.
Thanks, Mark. I have the pleasure of moderating today's session. The Scientific Planning Committee consisted of myself, Dr. Carrier, and Dr. Siegel. Next slide. And joining us on this panel, we have an esteemed group of guests here that we'll hear from Dr. Survey, joining us from Windsor, Dr. Drury, from Vancouver, Dr. Kelly from Halifax, and Dr. Sang from Toronto. So truly representing the, coast-to-coast thrombosis expertise. These are our conflicts of interest, none of which are directly relevant to today's talk. And this program receives support from Leo Pharma in the form of an unrestricted educational grant. The speakers and panelists received an honorarium. The content of this presentation was directed by the Scientific Planning Committee. And these are our learning objectives today. And we're going to challenge our panelists with discussing the diagnostic and initial management principles for patients with acute and extensive VTE. We're going to examine how renal impairment influences anticoagulant selection. And we're going to talk about how to dose anticoagulants in patients with suspected or confirmed VTE. We're going to also discuss some approaches to integrating evidence-based guidelines and clinical judgment and shared decision-making when managing these highly complex VTE scenarios in real practice. And with that said, I'll pass it over to Mark to lead us through case one.
Thank you very much, Siraj. And again, just for the audience to know, these are sort of real cases that we face on a regular basis in our clinical practice. And these cases have not been seen by Dr. Survey, Dr. Drury, Dr. Kelly, and Dr. Sang. So just like you, they'll be getting the information at the same time, and we'll try to modulate what we do in clinical practice, really learning from each other about how we approach different cases. And really, you'll see there's a number of different answers possible. Most of them are reasonable. It will really depend on your expertise, your experience, what you have available in your own centers. There's multiple ways to manage these different cases. And really, it's just a time for us to approach these challenging cases and learn from each other and see where we can, how we can manage them and hopefully generate good discussion, because these cases are controversial at best. And, the data surrounding clinical guidance can be limited sometimes or scarce. So I think we'll all learn from each other and generate a good discussion. So the first case is for an extensive deep vein thrombosis of the lower extremity. So this is an 18-year-old female presented with progressive sudden onset of the left lower limb with left lower limb swelling and pain. No real shortness of breath, chest pain, hemoptysis, no significant past medical history, no familial history of venous thromboembolic disease. She was recently started on oral contraceptive 3 months ago for acne. And on examination, her weight is 88 kilograms. Her vital signs are within normal limit. She really does have a big leg, whole leg swelling, tenderness over the deep vessels. The pulse are still present. You're not worrying about vascular compromise. Cap refill is 2 seconds. You do quick blood work, and the CBC is reasonable. Normal hemoglobin, platelet count, renal function is normal. She's not pregnant. Lactate is 1. The D-dimer is elevated. So obviously, you're suspecting this is a Thrombosis Canada webinar, so we're suspecting a deep vein thrombosis. We're going to do an ultrasound imaging, and that shows like a pretty extensive deep vein thrombosis. You can see that there's deep vein thrombosis starting in the tibial and perineal trunk all the way up to the vena cava present near the umbilicus. So left lower extremity extensive deep vein thrombosis is present when you're assessing the patient at the bedside in the emergency room. So just to open up to the different panelists, we'll start with the first question. And then I want the audience to also think what they would do in that particular scenario, because there's a number of different things that what can do, and that could depend on the access and resources you have available. Are you going to start right away with hospitalization and consider urgent catheter-based intervention, thrombolysis, or thrombectomy? Are you going to say, well, this is a young individual, we still have time, so we'll start anticoagulation, we'll do close follow-up for reevaluation with catheter-based intervention down the road if you have access to a thrombosis clinic, for example, in your center? Or are you going to say extensive or proximal deep vein thrombosis doesn't really matter? I'm treating these clots in a very similar fashion. I'm going to do what I usually do with usual follow-up, as she's unlikely to require escalation of care for additional or more invasive procedures. So as you're filling in these questions and answering the questions, we'll have a look in a second. Maybe I'll start with you, and then I think we can be on a first name basis, right? So Andrea, what would you do in Windsor?
Oh no. So, you know, it, generally, I guess the predicament here is whether there would be consideration for some form of catheter-based intervention, although it certainly does not seem as though there's a concern for a phlegmasia. We know that she's certainly very high risk for developing the post-thrombotic syndrome in light of the extensive nature of the clot. And, there was that subgroup analysis of the ATTRACT trial that did suggest that some people maybe had benefit in terms of lower or less severe post-thrombotic syndrome. In our center, there's not as much familiarity with PCDT in this setting, so
Mhm.
I would be probably leaning between probably having her admitted to hospital, but not necessarily to undergo an intervention. Although I wouldn't mind to get an input from my vascular surgery colleagues, but I would likely start her on therapeutic low molecular weight heparin up front. And we do have a thrombosis clinic where we could facilitate close outpatient follow up, assuming that she was having appropriate clinical improvement.
Right. That makes total sense. And then, as I mentioned, there's no right or wrong answer. And I think that really goes along with what I would do. Taylor, what would you do?
Yeah, at St. Paul's where I work, there's fairly easy access to interventional radiology. I mean, if anything, we find that if we call them, they will do the procedure in many cases. I mean, I would say from my perspective for this case, I would probably lean more strongly towards going right for catheter-directed thrombolysis or thrombectomy, some sort of advanced therapy, unless the patient themselves like really didn't want it. And then I think it would be very reasonable to try oral anticoagulation, or often in these cases when they're really symptomatic, we'll start them on low molecular weight heparin for a period of time, close follow-up, and maybe they have more time to think about if they are interested in more advanced therapies. But if they were accepting of it up front and we had access to it, then that's likely the route that I would go down.
Something you would consider. And this is aligning with what the folks online are saying. So 46% of folks said I would probably do outpatient close follow-up for evaluation. And then 41% said hospitalization as she requires an urgent catheter-based intervention. And you can see that it depends a little bit on your own experience, what is available in your own center, but also, it's hard because I'm just writing it up, but when you're assessing the patients, you'll have a sense of how significant the pain is for sure. And when you're starting, uh, Tyler, you mentioned starting anticoagulation. Sometimes you said you like to use a low microweight heparin in that setting. Um, Eric, what do you do when you initiate anticoagulation for these big deep vein thromboses?
I would usually use therapeutic dose low molecular weight heparin. So it depends on what you have at your hospital. So where I work in Toronto, we would typically use dalteparin 100 units per kilogram twice daily. But any of these options, like I guess I would probably select two for. Sorry, I'll let the audience answer, but I would use some therapeutic dose of low molecular weight heparin.
Okay. And why not an oral anticoagulant?
Um, because it makes me feel better. I
Yeah,
have
that's
not
okay.
seen, yeah, honestly, I have not seen good evidence. Maybe someone from the audience knows of a study that would say one way or the other. The reality is these are small groups of patients, and I think there's a bit more comfort, especially if there's consideration for an intervention. I'm not saying that patient needs to be on IV heparin because frequently these procedures are done while patients are on therapeutic dose anticoagulation. But I think having something that is weight-based and tried and tested makes us feel more comfortable.
And then Eric, would you go right away like Tyler in BC to enter like catheter-directed, or would you start anticoagulation and see?
I think it depends, as you said, on how the patient is feeling. Like, can she walk? How much pain is she in? Where I work, we would typically discharge the patient, assuming there's extremely close follow-up. Like
Yeah.
this isn't someone who needs to be seen in a couple weeks. She needs to be seen like tomorrow or the next day.
To make sure things are evolving in the same way. And in Halifax, Erica, would you do the same?
Yeah, I think she's someone, like I said, she's like kind of teetering on that edge, whether or not going right to catheter-directed thrombolytics will change her overall post-thrombotic syndrome. I guess it depends like clinically how she is, but certainly starting her on low molecular weight heparin would be what I would do up front. And, there seems to be maybe that little bit of an anti-inflammatory effect and everything that seems to help people a little bit. And if we were going to go to do an intervention, I think, you have that comfort of already being on something.
Yeah. So I guess we're aligning with what most of the audience said. 90% of them will start low molecular weight heparin, 3% IV heparin. Maybe these are patients that are going to be admitted to hospital, maybe to be a bit more aggressive with catheter-directed intervention sooner. About 7% said apixaban or rivaroxaban in that particular setting. And just to follow up on what you said, Erica, I like it because we say sometimes there's pleiotropic effect of low molecular weight heparin. Is there potential anti-inflammatory properties to them? We've learned through COVID that maybe heparin or low molecular weight heparin may have anti-inflammatory effects and may reduce leukocyte endothelium adhesion of different particles and may be binding, neutralizing pro-inflammation cytokines and chemokines and lower measured inflammatory markers for sure in COVID patients, right? That's why when these trials were done, show that maybe it has an effect on thromboinflammation. And then there's maybe a little bit of evidence in that setting too. We're going to look at old data, of course, because there's not recent data to it, but this is a systematic review and meta-analysis that was done back in 2011 by Russell Hall and colleagues from Calgary. And you can see here on the top comparing low molecular weight heparin, specifically tinzaparin, versus vitamin K antagonist or warfarin. And at the bottom plot, or the forest plot, you're seeing the different low molecular weight heparins compared to vitamin K antagonist. And it seems to show that a lower venous ulcers incidence with low molecular weight heparin, a trends towards decreased risk of self-reported post-thrombotic syndrome compared to vitamin K antagonist, certainly better recanalization with low molecular weight heparin. And this has been carried in clinical practice saying, well, we really think that low molecular weight heparin may be a good agent up front for these big clots, trying to provide better recanalization, hopefully less PTS and less venous ulcers. But is it really a pleiotropic effect or anti-inflammatory effect of low molecular weight heparin? Or is it really just good anticoagulation? Because we're comparing the vitamin K antagonist, right, with a time and therapeutic range that can be sometimes difficult to target. So does these long chains really have an anti-inflammatory effect? Or is it because they're just a better anticoagulant than warfarin? And if that is the case, then maybe we would see similar findings with rivaroxaban and apixaban. And then there's a little bit of data to this. So the Danish people, they had a long or nationwide cohort study of 20,000 people of patients that are starting anticoagulation for incident VTE and follow them over time. So you can see time since index events up to 3 years. And you can see that the incidence of PTS was slightly lower in patients receiving rivaroxaban. The hazard ratio is about 0.88, but it did not reach statistical significance in that particular setting. There's post-hoc analysis of the Einstein studies that are showing somewhat similar findings. So maybe rivaroxaban or maybe directal anticoagulant may be associated with slightly lower risk of PTS, however, never reach clinical significance. So I guess we won't know. We tried to do a trial that could help us, finally have the answer to this. This was the tile randomized controlled trial. And I'm not sure if some of you have participated in it, but it was exactly that. So patients with acute symptomatic femoral iliac vein deep vein thrombosis to be randomized to rivaroxaban 15 milligrams POB80 for 21 days, or tinzaparin at therapeutic dosing for 21 days. Then everybody was going on rivaroxaban and then following patients for 90 days to see if we could see any difference in PTS. Unfortunately, that was a really hard study to do. They had to stop recruitment. So we'll actually, maybe it's a bit sad, we'll actually never really know if low-molecular heparin has anti-inflammatory properties or is it anticoagulant effect. But I agree with what was said on the panel. I usually also would use a low-molecular heparin at therapeutic dosing for a few weeks just to try to see if we can settle things down. And often these patients need a lot of anticoagulation. We need to be patient with these symptoms. And occasionally, I'm not sure if anybody on the panel have done this, but occasionally when they have a lot of symptoms, I've also used short courses of celecoxib to help with and to get rid of the swelling. I see Eric and Andrea nodding. Have you used that as well to try to help with the symptoms for these patients? Yeah. Okay. So I guess the patient, no offense, Tyler, but in Ottawa, we don't have access as readily available as you do. So the patient was managed in the outpatient setting, was started on therapeutic dosing of low-molecular heparin. But any of the previous management course was very reasonable. We decided to use dalteparin at therapeutic dosing in that particular setting. And then in follow-up 1 week after, as Eric mentioned, we need to do a close follow-up for these patients. There's just really modest improvement in symptoms. The leg remains very painful, tight. She comes to clinic, she's in a wheelchair, she has difficulty mobilizing. There's still no evidence of limb ischemia, no suggestion of phlegmasia. But what would you do at that particular time? I won't ask Tyler because the clot would already be gone. But if you're anybody else, Andrea, at this point in time, would you be, considering a different management option, or would you be patient in that particular setting? And then the different options, so I'm trying to move the slide to the next one so you can see the different option. There we go. So would you continue low-molecular heparin, saying we need to be patient, maybe I'll add a little bit of anti-inflammatory celecoxib or something like that, reassess in 1 or 2 weeks? Would you say this is going nowhere, I'm just going to boost up the low-molecular heparin by 20%? Would you say, well, maybe we can switch to a direct anticoagulant at this point in time? Would you now admit to hospital, IV heparin, consider catheter-based therapy, or would you do that in the setting of low-molecular heparin or increasing the dose of low-molecular heparin or a DOAC? What would you do at this point? You're 1 week in.
I think at this juncture, I would stay the course. I wouldn't change the dosing. I would be making sure I wouldn't be leaving this to a 2-week follow-up. I'd be having her back to see me very promptly within a week. I am burned with a little bit of a previous experience in training where a patient had an intracranial hemorrhage when they were sent for CTD. So I do have a little bit of that anxiety in my background, but I would stay the course at this point and be arranging a 1 week very careful follow-up with obviously post instruction on when to attend the emergency room if needed in the interim.
So that's perfectly fine, right? You wouldn't expect to see a whole lot of difference after a week in symptoms, right? The clot is huge. You probably need to be, careful in the reassessment and things. Eric, what would you do at this point? Do you agree that you would just continue the course, or is that getting through your threshold and saying, I need to talk to a colleague to see if catheter-based therapy is reasonable?
Yeah, this is a tough situation. I think it depends on what resources you have available,
Yeah.
and what the local expertise is. I think everyone would agree that this patient, you would have hoped that she was doing better at this point, and that's why this is a challenging situation. What I would likely do, because just functionally she's not improving, it's so extensive, I would likely choose option 5, and try to get urgent IR assessment for some sort of procedure. At our hospital, we would often use or think about mechanical thrombectomy versus catheter-directed pharmacomechanical CDT, depending on the situation.
Okay.
But a few years ago, it would have been option 4. It would have been admit to hospital, IV heparin, um, CDT probably.
Okay. Things are changing quickly too, and we'll have a look to see if we have good data supportive of. Sometimes we don't, so we need to make these treatment decisions. Erica, have we crossed the threshold? Tyler with the first one using catheter-based therapy. Eric is now asking for advice. What about you?
Yeah, I mean she's young, and I feel like with these young patients, if they're not seeing improvement within the first week, like it's going to be the 2 months and they're still going to be. So I think talking to that like interventional radiology at this point would be very reasonable. And in our center, we would admit them, and we're doing catheter directed.
Sounds good.
So we would chat with them, I think, and I don't think there's a reason to increase low molecular weight heparin or anything at this point. But I think, chat with them, see if it's reasonable. If not, stay the course.
Exactly. And then I agree with the audience, right? And then it's exactly highlighting what you said. So 37% will do what Andrea is suggesting, so which is totally reasonable. We're not expecting the symptoms to be much better by now. It will take 3 to 4 weeks. We need to be patient. In the chat, I saw Siraj saying sometimes for the symptoms, short course of celecoxib may be reasonable. 44% are going with Erica and Eric saying, well, in my center, maybe I could have access to an interventional radiologist. Maybe I would have a discussion with them, or IV heparin, consider catheter-based therapy. So I think these are the right options. I don't think I would increase the dose by 20%. There's no recurrence, there's no extension at this point in time, or concerns about that. And switching to a direct oral anticoagulant is not a bad option, but I don't think it will add too much at this point in time. The patient's already well anticoagulated with a parenteral agent. I don't think we need to do that. So you mentioned that, there's different therapies. Like a few years ago, it would be catheter-directed thrombolytics. Now we do a lot of catheter-directed thrombectomies. Part of the issues is we all have little data to help us in clinical practice. So when we look at the different clinical trials that are available, we only have a few that we can look into, and they're not big trials. And Andrea already mentioned the ATTRACT trial, but really from a catheter-based directed thrombolytics, we only have CAVENT, which is CDT versus anticoagulation, relatively small or modest number, 210 patients, open label randomized control trial. These were iliofemoral deep vein thrombosis, and they compared CDT with alteplase to anticoagulation in these patients. They had two primary outcomes: frequency of PTS at 24 months, and then iliofemoral patency at 6 months. And when you look at the PTS at 2 years, they showed an absolute risk reduction of about 14%, hence the arrow down for PTS in green, but that seemed to be associated with slightly increased risk of bleeding, so maybe selected benefit in these patients. The ATTRACT trial is the large randomized controlled trial published in the New England Journal of Medicine. Eric mentioned mechanical catheter-directed thrombolysis versus anticoagulation alone. And then the main result really was that they didn't show any overall difference in PTS between months 6 and 24, so 47% versus 48%. And they had an increase in early major bleeding, as Andrea mentioned. So it was 1.7 versus 0.3. So, risk-benefit ratio that is a little bit unclear, but Andrea already mentioned that in moderate to severe PTS, remember, when we talk about PTS, we use the Vellalta score. PTS is a Vellalta score of 5 or more, and then moderate to severe PTS is Vellalta score of 10, more than 10. And when they looked at these particular patients in iliofemoral DVT, then they saw a relative risk reduction in moderate to severe PTS of about 30%, and that was statistically significant. So maybe in a subgroup of patient that might be desirable. And the CAVA is the smallest of the studies, 180 patients, iliofemoral, and then they use ultrasound accelerated CDT compared to anticoagulation. showed no difference after 1 year in PTS, slightly increased risk in major bleeding. But as Eric mentioned, often we now use mechanical thrombectomy, and we don't have a whole lot of randomized data to that. We have a lot of registries, and it looks like it may be helping symptoms. It looks like the bleeding risk is low, but randomized controlled trials are ongoing, the Defiance trial, so we'll have data at some point. But in the meantime, we still need to make practical decision and make decisions about this. So if you put all this together, the systematic review and meta-analysis showed lower PTS, especially moderate to severe PTS. But when you look at major bleeding, it's increasing the benefit. So maybe any PTS benefit needs to be trade-off, or the risk-benefit ratio needs to be carefully assessed compared to bleeding. So in our particular patient, we decided to have a discussion with interventional radiologists. I'm sorry, Andrea, I gave up too. I went to have a discussion with interventional radiologists. And as Taylor mentioned, as soon as you mention it, they're probably going to be keen on removing it. There's going to be no discussion about it. So the patient underwent successful mechanical thrombectomy. The decision was made to hospitalize the patient for catheter-based thrombolysis due to residual disease on post-thrombectomy venogram. So she was admitted for a couple of days, started on IV heparin, TPA through the catheter at the usual doses. Within the next few days, she had significant improvement, residual vein obstruction. We removed the TPA, it stopped, the catheter was discontinued, and the patient went home. So this is one way to do the clinical management, but I think the other options would have been very reasonable as well. Mm-hmm. So then the question for you and the audience is, what do you do on discharge? Do you discharge a patient on low microwave heparin? She was started on dalteparin, so do you discharge her on dalteparin? Do you use another low microwave heparin, enoxaparin or tinzaparin? Do you then feel comfortable with DOACs? And just to twist it, because she already had a week, you'll start her on 5 BID, or do you want to use the bigger doses for 7 days and then back on 5? Or do you prefer rivaroxaban because there's a 21-day higher dose, so you feel a bit more comfortable about risk of recurrence? What would you do? Erica, what's your go-to?
I guess, she's a pretty low risk of bleeding, but did also get TPA. It might not be unreasonable to send her home with a couple more weeks of low molecular weight heparin, but if she's really over the injections, then I would do apixaban without a loading dose.
Okay. So just so make sure you're committing, are you saying 2 weeks?
I'm going to go for 2. I'm going for 2. I'm committing with 2.
Okay.
I'll feel better with that.
2 weeks of low molecular weight heparin, then
another, a couple more weeks and reassess her.
I like it. Okay. Andrea?
Yeah, I think I kind of agree with Eric. I think it's a discussion too. Is there, and I probably wouldn't feel uncomfortable sending her on apixaban, but I do always feel like if I'm ever weighing anticoagulation in my mind, then I feel a little bit safer with low molecular weight. So if there's no element of injection fatigue, knowing I can, pick her up in clinic within a week or 2 of discharge, I probably would just continue her on the previously prescribed low molecular weight heparin that she was receiving. If there's, a significant element of injection fatigue and it's like, no way, I'm not doing this anymore, then I would likely go with the apixaban without the load, number 3.
Okay. Sounds good. Taylor?
I would go with the apixaban, no loading dose, 5 milligrams twice a day. To me, I guess the way I think about it, and please correct me if I'm wrong, I'm not aware of any trials that have studied this type of protocol post thrombolysis like this. But to me, we've removed the clot burden, we've removed the huge nidus of inflammation. She's feeling better. She's 7 days out. To me, I would have no issues with going with the apixaban 5 BID. Yeah. Right or wrong.
No data. If there was data, I wouldn't put it in a case. And finally, Eric, what's your recipe?
Low molecular weight heparin.
Okay.
After, I guess just because I think it's out of the fear of the unknown. The patient was very clearly hypercoagulable. for some time, and presumably the risk factor is going away, and the further you get, like the lower the risk of recurrence. But I I prefer to use something that's tried and tested. Maybe I'm just old school.
Well, no, I agree with you, and we'll see what we did. But if you look at the folks online, it's a little bit split. A majority would say 61% would feel comfortable with a Pixaban 5 BID. So, but some people would feel more comfortable with continuing on with the dalteparin upon discharge, probably for a couple more weeks, and then see where things are at that particular point in time. Interestingly, 20% still would have used the I don't want to say loading, but a higher dose of apixaban for 7 days than 5 milligrams POBID. So it looks like there's still a little bit of an element of, you know, maybe not low microwave heparin, but I don't feel too good about the risk of recurrence short term. So I'm going to use the bigger doses for 7 days and then 5 milligrams POBID thereafter. Well, Eric, I'm happy to tell you that just like you, I'm old school. So the patient was discharged, or maybe I'm just old, but the patient was discharged on dalteparin, and then patient was seen a couple weeks after discharge. At that time, she was doing well, no, remarkable recovery, no lower limb pain, significant improvement in swelling. She was ambulating okay, no bleeding, no heavy menstrual bleeding because she decided to stop we didn't go through that oral contraceptive because it was for acne and then didn't really want to continue it. She didn't have any heavy menstrual bleeding. So dalteparin was discontinued and apixaban 5 BID was started after a couple more weeks. And then we had discussion about compressive stockings and prescription was prescribed, provided just really for symptoms, not necessarily to prevent post-thrombotic syndrome, but she's an avid hockey player and was noticing some swelling at the end of the day. So maybe we'll stop here. And Siraj, do you have
Yeah,
questions in the chat?
there's lots of great audience questions, actually. I'm going to select a couple of them just for time, and we can respond to some of their others in chat, myself and Dr. Siegel. First question is actually, you mentioned that she was on birth control, right, for acne, but that didn't come up as part of the management. And so maybe briefly, could you just discuss your approach to managing this patient's OCP in light of the extensive clot? Would you discontinue it? If so, when?
Mhm. Well, any takers on the panel? Like personally, I tend to prefer that the woman continue oral contraceptive while they're on oral anticoagulation, especially early on, because they'll be on big doses of DOAC and can have heavy menstrual bleeding. I'm not overly concerned about recurrence or extension because this should be mitigated by the full dose anticoagulation. However, at the end of the 3 month period, or 6 months period, depending on risk stratification, we could have a discussion about that too. But that person, if you decide to stop anticoagulation, she will need to use an alternative. So, Mirena IUD, if possible, progesterone only, complement, contraceptive. So, I'm not sure if others on the panel, Eric, do you tend to continue as well, or do you stop?
I have to admit, by the time I'm seeing them, we don't see them like the next day. So
Okay.
I think almost every case they've been told already to stop it. And then if you're, eh, unfortunately, sometimes they've had a really heavy period. So in situations like this, so I would have no concerns about continuing it if it was, especially if the indication was heavy menstrual cycles.
Mhm.
Um, but often that it's already happened, fortunately.
Anybody else on the call that make that decision on a regular basis? What's your preference?
I'll usually continue as well if they're already on it, but the same with me, we're not seeing them immediately after. It's often already stopped. So, if making sure no heavy menstrual bleeding, if so, providing an alternative like tranexamic acid. And a lot of these patients, because they've had the clot on the birth control, even if you say it's okay to continue, they're very hesitant.
Yeah, that's what happened here. I
Yeah.
had a discussion with her and I said, I actually prefer you continue, but she assured me she didn't have heavy menstrual bleeding before starting. It was only for acne. And at the end of the day, it's their choice. But yeah, she decided to stop it. Tyler?
Yeah, we usually, the way our kind of patient pathways are set up here, we usually see them within kind of 24 to 48 hours. I usually find myself seeing them and telling them to restart it because they've been seeing it emerge, they've been told to stop. And certainly as some of my colleagues here have mentioned, if there's any history of menorrhagia or that's the indication for the OCP, then for sure I'm like, definitely please restart it, because we know, as you mentioned, you're going to be on high dose anticoagulation. Your menstrual cycles are invariably going to be much heavier. And so why not take the time over the next 3 months to try and sort out a non-estrogen based contraceptive down the road is typically what I've done.
Yeah, sometimes at least it gives you a bit of time to make these changes in the decision on it. Okay.
That's great. Thank you. And Mark, I'll ask one more question because a lot of really good questions here. Again, we'll try to answer some of these in the chat, but there are a couple of questions about the logistics about, how much involvement does a thrombosis consultant really have in deciding what procedure gets done for the patient? Because some centers have access to both thrombectomy and pharmacomechanical, catheter-based procedures. So how is the decision made? And does it involve just the interventional radiologist or also the thrombosis consultant? And an add-on question to that, how do you anticoagulate the patient after the procedure? Must you use unfractionated heparin, or could you use low molecular weight heparin immediately after the procedure?
Tyler, are you involved in these decisions, and how do you anticoagulate afterwards? Taylor?
Oh, sorry. We're I would like right after the procedure, the TPA infusion is done. Like at least at our center here, they'll run the infusion over 24 hours and then they'll do a relook venogram. Yeah, we're all good. We're going to stop the TPA and then we'll start low molecular weight heparin that evening.
Okay.
We try and avoid IV heparin at all costs. I can see, as many of you've seen, I saw in those new PE guidelines from the AHA that have just come out. It's kind of nice. They said low molecular weight heparin over IV heparin for all cases, even if they're going to consider advanced therapies. And so I would say I'm certainly a believer in that. So yeah, it would be low molecular weight heparin over IV heparin as much as possible.
And you provide an insight on thrombectomy versus thrombolysis, catheter-directed?
Oh, no. I guess the way, as I was kind of mentioning before, like most of the time, if, at the various sites here in BC, that decision, it depends on who Emerge calls first. We've certainly found if they call, an interventionalist, then there tends to be an intervention that is arranged. It's a bit different whoever they call first, but often if we've gone through this case, we've decided, okay, yeah, we think some advanced therapy would be warranted. I myself have not had any impact in terms of, yes, I think catheter-directed thrombolysis versus thrombectomy or some sort of combination, unless in your patient assessment you've identified, yes, this person is very high risk of bleeding. I really think a thrombectomy on its own would be better. Take out as much as you can, and we'll deal with the rest of it afterwards. But for the average patient, we kind of leave it up to the interventionalists and their tools.
I think, Suraj, the answer to that would be really, we provide, like Andrea mentioned, we see the patient on a regular basis. We follow the patients. We would let them know when we think there's maybe a role for catheter-based therapies. We probably should provide them with our overall assessment of bleeding risk, saying, I'm worried about this particular patient because of XYZ reason. And then I usually tend to let them decide on the techniques that they'll be using. And I'm not sure if Eric, Erica, or Andrea, you have other things, but I'm not usually overly involved, but I take over afterwards based on the anticoagulation. And similar to Tyler, I would use low molecular weight heparin in that setting. And I briefly saw, should we put an IVC filter in that setting? I think there's practice variation from a center to center. In Ottawa, we would put an IVC filter while these procedures are being conducted and be removed after, but it will depend on your interventional radiologist.
That's great. Thanks, Mark. I think we'll answer some of the other questions in chat and we'll pass the mic on to you for the second case.
Okay, perfect. Andrea, Tyler, Erica, Eric, you're good? Yeah, you're surviving. It's all not too bad. Okay. So the second case is for severe renal dysfunction. So similarly, no right or wrong answer. And then again, we're learning from what happens in BC versus Halifax versus Ontario. So it's just a good opportunity to learn from each other. So 73-year-old female presented to the emergency room at midnight with shortness of breath on exertion for 6 days. No chest pain, no hemoptysis, shortness of breath progressively worse, difficulty climbing stairs, no lower extremity symptoms. Patient is known to have hypertension, type 2 diabetes, chronic kidney disease similar to hypertensive nephrosclerosis, no personal history of VTE. Medication list on exam, she's 70 kilograms, she's sitting well on room air, she has good blood pressure, good pulse, breathing maybe a little bit quickly. She's comfortable though when she's sitting. The exam is otherwise normal. She has a reasonable CBC, hemoglobin is 102, D-dimer is high, creatinine is high, estimated creatinine clearance gives you 12 cc's per minute. Tropes are negative, BNP is negative, chest X-ray chill, nil acute. This is a Thrombosis Canada case, so obviously we're suspected PE. You're concerned about creatinine, so you do a VQ scan in that particular setting. Interpretation is high probability VQ scan based on PIOPED criteria, or SPEC VQ is positive for PE, multiple segmental, subsegmental defects in the bilaterally. So the first question, I guess, for the audience and the panelists is, do you feel comfortable managing this patient in the outpatient setting based on clot burden, renal function? So yes, I feel comfortable in the outpatient management, follow-up in thrombosis unit or close by, and I would use therapeutic dose of low microweight heparin. I would do the same, but I would feel comfortable with a DOAC with the usual higher doses, apixaban for 7 days, rivaroxaban for 21 days. I would hospitalize this patient and start IV heparin because of renal function, because of clot burden, or I would hospitalize and initiate low microweight heparin or DOAC. Eric, what would you do if you called to the emergency room?
I would start low microweight heparin,
In the
therapeutic
outpatient setting?
dose. Sorry?
In the outpatient setting, would you admit?
If the patient sounds like they're stable from a respiratory perspective and reliable, so I would be comfortable managing this as an outpatient.
Okay. Andrea?
I agree. It sounds like she's hemodynamically stable. I would have her seen quickly upon emergency room discharge, and I would feel comfortable with low molecular weight heparin. I would prefer tinzaparin in this scenario in light of her renal dysfunction.
And because of the bigger molecules, so less likely to be renal dependent for elimination. Okay. Okay, Erica, Halifax, what do you guys do?
Like with that EGFR, it's kind of like that iffy kind of point for low molecular weight heparin. So I guess, depending on her comorbidities and everything and how she's doing, she's vitally stable. It would be a toss-up. And a lot of times I think this patient would be admitted here for unfractionated heparin and then looking at bridging to warfarin. And I would say we don't have a lot of the comfort with that EGFR with low molecular weight heparin, but I think if we were to pick tinzaparin would be the option.
So again, just to make sure you're committing.
I'm not a committing person. I know.
So IV heparin and hospitalization IV heparin.
Yeah, which isn't ideal. I would love to use low molecular weight heparin, but this patient probably would have already been seen by medicine and started on unfractionated heparin, to be honest.
Blame medicine. Okay. Tyler in BC, what do you do?
If I put on my medicine hat for a quick second, is that I guess it would depend, is that creatinine her baseline, or does she have like a rapidly worsening? No, this is her baseline.
It looks like it's baseline, her
This is
usual.
her baseline.
Yeah.
Okay. Yeah, I would, if we, as everyone has mentioned, if she is, hemodynamically stable, doesn't need admission purely for the PE perspective, which it sounds like she does not, then I would treat her as an outpatient. And either tinzaparin or apixaban. I'm going to commit in a second. Her weight is fine. Yeah, I think I would, with her creatinine clearance of 12, kind of it's right around that 15, creatinine clearance 15 for, Health Canada approval for apixaban, recognizing that's just based on pharmacokinetic data. But I've always been under the assumption, if it's good enough for Health Canada, it's good enough for me. So I have certainly used apixaban in these situations. If this truly is her baseline creatinine, I would give her the 10 milligrams BID and then the usual protocol after that. If it was getting a little bit worse, then I'd probably use tinzaparin. But I think for my answer here, I would pick option 2 with apixaban, not rivaroxaban.
Okay, so I love it. So we have hospitalization, IV heparin, bridging a vitamin K antagonist. We have outpatient low microwave heparin, seems like a preference for tinzaparin. And then in BC, you're going to send this patient home on a PIX10 BID. So, and it's highlighting that there's not a whole lot of good data, and that's reflective of clinical practice. And when there's heterogeneity, when we do different things, it's because we have different interpretation and different experience. And it's actually what is reflected here. So, most people would feel comfortable with low microwave heparin. We'll come back to the different agents in a second. 26% will do just like Erica, and then admit this patients with IV heparin. And then 13% will follow Taylor's lead and switch that patient or treat that patient with a direct anticoagulant. Excellent. And then you're all right that I just wanted to highlight that this patient seems to have big clot burden. When you actually use the different tools we sometimes use to make a decision about hospitalization or not, they have pros and cons, but often we use the PESI or the simplified PESI. The patient doesn't have any criterias for it. When you look at the ESC risk stratification, the patient, although we didn't specifically look at the right ventricle, but probably would be intermediate low or low risk category. So I agree with you, would probably feel comfortable from a PE burden perspective managing this patient in the outpatient setting. Now, maybe hospitalization is required, as Erica mentioned, because of the renal dysfunction. There's discrepancy. So we'll leave Erica and Tyler out of this one because they've already committed to IV heparin and apixaban. Well, maybe Tyler will ask you about apixaban in a minute, but from Andrea and Eric, what type of low microwave heparin would you use and what doses at therapeutic dosing? So here is a little bit funny, and then you're probably wondering why I'm putting these funny doses. So these are either product monograph or certain recommendation from different clinical practice guidelines, let's say. So there's no wrong answer here, but I would just want to say, what's your go-to?
I would probably choose 6 myself. So I would feel most
Okay.
comfortable with tinzaparin as the low molecular weight heparin of choice, based on some of the data from the Trivet trial. And I would not empirically dose reduce her. We would be making sure that we're minimizing other sort of bleed risk in terms of, avoidance of NSAIDs and other sort of over-the-counter agents and herbal supplements and remedies and blood pressure control and alcohol avoidance and all of that. But I would likely start at the full therapeutic dose.
And bridging to vitamin K antagonist eventually.
Yes.
Okay. So, saying tinzaparin, large molecule, less dependent on renal clearance, more likely to bind to reticuloendothelial system, and therefore unlikely to bioaccumulate short term up to warfarin. Okay. Eric?
My go-to for the most part has been 6 as well. Therapeutic dose Tinza bridging to warfarin. Although I will say, I think in the past probably year, I have had patients where we've started with 7 days of therapeutic dose Tinza and then gone to 5 BID of apixaban thereafter. I'm kind of avoiding the load with apixaban, but then using the therapeutic dose based on no evidence.
Okay. Sounds good. That sounds very reasonable. Okay. Tyler, do you use the usual dosing the 10 milligrams BID for 7 days and 5 milligrams POBID thereafter? Or, for patients with stage 5 chronic kidney disease, do you go down to 2.5 BID? Because in hemodialysis, there's a little bit of evidence maybe it's not bioaccumulating.
Yeah, I guess there's in her particular situation with her creatinine clearance of 12, like I always have in my head a creatinine clearance of 15, and above that I have had, in my personal practice, I would use apixaban without issue. It's just below that. If it was possible, if it was logistically feasible for her to do low molecular weight heparin injections, then I certainly agree with Eric. I have done the 7 days of tinzaparin to avoid that loading dose and renal dysfunction, and then 5 milligrams BID. But if, she lives alone, she can't do injections, I certainly wouldn't want to bring her into the hospital just for that. And again, with this particular case with that creatinine clearance, I would do the 10 milligrams BID and then the usual 5 after that.
Okay. And it's aligning with what was said in the survey as well. So most people would agree with Eric and Andrea and would have done the tinzaparin bridging the vitamin K antagonist. I didn't put the option. I was running out of space about the 7 days of tinzaparin and apixaban. I think it's a reasonable option too. 15% would do what Tyler would do as well. And then again, people have said, Eric, of IV heparin bridging a vitamin K antagonist, certainly a very safe option in that particular setting, for which there's probably some data in the setting of renal dysfunction, no doubt. If you decide to use low molecular weight heparin, Andrea and Eric, you're in Windsor and Toronto, so you both have access, I'm assuming, to anti-10A level. Do you do them if you use it for a short course?
If the expected course is like 7 days, increasingly I haven't been checking because by the time the result comes back, you're only looking at such a short course of therapy. If there are patients who aren't extended, like beyond a week, then certainly I'll be checking typically trough levels. Typically, I think as Suraj said in the chat, before the 5th dose. So after the drug is at steady state to assess for bioaccumulation.
Do you have a certain threshold you use for a trough?
I've seen different numbers reported. I've typically used 0.4 as my number. Our hospital, there is a dosing algorithm that suggests different dose adjustments based on the trough as well.
Okay. The direct study used a threshold of 0.4 Canadian data, worth celebrating. So I agree with you. Andrea, do you do anti-10A level on a regular basis?
Not on a regular basis, so it's send out testing for us. So it does
Okay.
take about 5 to 7 days to get the results back, which are not particularly helpful. But if I did have a patient on an extended course, then yes, we would be ordering the testing and similarly evaluating the trough.
Yeah, so by the time you get the trough level, then your patient will be therapeutic on vitamin K antagonist. And as you mentioned, the Trevitt trial or study that was done by Mark Crowder, Wendy Lim in Hamilton a few years back showed reassuring data, maybe 20% dose accumulation based on biomarkers or trough anti-10A level, but no difference in bleeding. So reassuring data that way. Okay, Tyler, you're using 10 milligrams POBAD of apixaban, a creatinine clearance of 12, then followed by 5 milligrams POBAD. Do you do a trough or a peak DOAC plasma concentration or no?
Not in that early setting.
Okay.
In someone like this, I would certainly watch their renal function, fairly closely. Obviously we're all going to follow them clinically. If their renal function started to get worse, then I would check a trough DOAC concentration. Again, not, as we're all aware, there's really no therapeutic range.
Yeah,
It's really just to kind of make myself feel better that the number isn't really high,
Yeah, you want to make sure that they're on the treatment range, right? At least up to the 95th percentile. If they're way off, then maybe changing therapy might be something to consider in that time. Okay.
Mhm.
And then I just wanted to highlight, and everybody knows this, but this is really chronic kidney disease stage 5, right? So when there's creatinine clearance of less than 15 cc's per minute. And there's really little data to help us make these treatment decisions. Often these patients are mixed with hemodialysis patient. So it's really hard to tease out the differences between, anticoagulation management while they're on hemodialysis versus chronic kidney disease with a creatinine clearance of less than 15 cc's per minute. And recently, there's been clinical practice guidance, I would say, from the UK, and they provide a little bit of guidance on what you should consider specifically for chronic kidney disease stage 5. And then they say in that particular setting, low microwave heparin, as we mentioned, bridging to vitamin K antagonist may be very, very reasonable. IV unfractionated heparin bridging to vitamin K antagonist would be reasonable. And then you can see that depending on the dosing, access to levels, comfort measures, they're providing an alternative dosing regimen for the different low microwave heparin, especially, I guess, if you're going to use it long term. So I would agree, a lot of folks have said tinzaparin, that feel comfortable with tinzaparin at therapeutic dosing for a few days without any concerns of bioaccumulation. But if you in the setting of it takes longer, for example, to get into the right therapeutic range, sometimes we say it's going to be 7 days, but sometimes it's 2 weeks and the patient still has fluctuating INRs, then these might be good things to keep in mind, that maybe a slight dose reduction, if we're not able to do trough level, for example, maybe something to consider in that particular setting. So it's something new that deserved a little bit of attention. New Kidney Association from the UK clinical practice guidance, so maybe helpful for the occasional patient. And unfortunately, we'll never know what is the right thing to do. So the French had the Verdict trial, where the patients with acute VTE and renal failure, not the type of renal failure we're talking about, but those that had moderate to severe renal dysfunction, were randomized to low microwave heparin, a vitamin K antagonist, or rivaroxaban or apixaban. And they were looking at different dosing of apixaban and rivaroxaban, slight dose reduction. That's why I've included it as one of the potential options. And that may become handy for the occasional patients as well. But for our particular patient, we decided to use tinzaparin at therapeutic dosing, similar to what Eric and Andrea were discussing. Trough anti-tenia level, I don't do it on a regular basis either, but for what it's worth, it was reassuring and less than 0.4, as Eric mentioned, so no signs of bioaccumulation. The patient was bridged to vitamin K antagonist with an INR of 2 to 3. 6 months of anticoagulation, deemed to be at high risk of recurrent event based on age and VDAS D-dimer or other parameters that you see fit. And, the patient is tired to be on INR now. Obviously, Tyler doesn't have that problem because the patient's been on apixaban for a little while. But then if you've decided to use vitamin K antagonists, like over 50% of people, what would you do? Do you say, you know what, we don't have a whole lot of data for singular prevention in chronic kidney disease stage 5, we'll continue warfarin the same target? We'll say, well, I'll give you a break. I feel a little bit more comfortable with low microwave heparin for XYZ reason. Or are we going to use one of the direct anticoagulant in that particular setting? Erica, what do you do?
I think in this case, it'd be reasonable. I would do number 4. They've had
Okay.
6 months of treatment looking at, and there's a lot more evidence for, dose reduction of apixaban in this, decreased, like with this EGFR, with bleeding and everything as well, like showing, decreased thrombotic events as well as bleeding. So I think this would be a reasonable alternative,
And what if
especially.
her INR was perfect, like good time in therapeutic range? Do you even address it? Do you continue warfarin? Do you
I'd
switch?
probably just continue warfarin in that case if they're doing well on it. But if not, warfarin's a great drug. So if they're doing well on it, it's, therapeutic. Why switch it? So unless there's a problem, but if there was, then I think switching it would be,
Okay, so option 4 for you.
yeah.
Andrea?
I agree. I would be comfortable switching over to the Apix low dose after 6 months of anticoagulation. Just recognizing the data is somewhat limited, and I think largely in the setting of retrospective reviews and not a whole lot of prospective data. But I think we do have more comfort with the lower dose of apixaban at these creatinine clearances.
Eric?
I'd be comfortable with low dose of apixaban. If the patient is also happy with warfarin and having the INRs checked once a month, then that's also reasonable. This is assuming that we think that the benefit outweighs the ongoing bleeding risk, which is always
Yeah.
substantial in these patients. Yeah, 4 sounds good to me.
And very good point, Eric. I didn't make the emphasis on that, but we need to ensure that the risk-benefit ratio is favoring. And Taylor, you started 5 milligrams early on. Do you tend to dose reduce in that patient population for extended duration?
Yes, yeah. In this case, I would go with number 4, the reduced dose. But as Eric was saying, like if there's been bleeding issues, or say by the time we're seeing her at the 6-month follow-up, she's now on dialysis, I would stop it. I would say there's almost no situation where I would continue the secondary prevention in someone on dialysis. So yeah, I'd pick 4 in this case.
Due to concern of bleeding, you feel like the risk-benefit ratio is, as Eric mentioned, is now crossing.
Exactly, unless there was some other, nuance situation, but I would say in general for unprovoked VTE, once they finish their treatment course, they're a dialysis patient. You tended not to opt for long-term anticoagulation just for fear of the risk of major bleeding.
And it's the first time tonight we have full agreement across our panelists. And this is fantastic because 81% of the audience also said they would feel comfortable with apixaban 2.5 milligrams POBID. And then 10% would say, similar to what Erica and Eric mentioned, we can continue on with warfarin. I made the point to try to push you a little bit that she was unhappy in having frequent INR testing, but the two options are very reasonable. And this is actually aligning with what was said in these new guidelines from the United Kingdom as well, where you can continue vitamin K antagonists if it's going well. If the time in therapeutic range is not as high as one would hope, then we can consider 2.5 milligrams POBID in that particular setting. Okay, so I just wanted to highlight that if you're interested into this topic, there's a little bit of data, an RPTH systematic review that was recently published. They looked at all the different levels of anticoagulation or chronic kidney disease. Again, as I mentioned, in that particular setting, stage 5 and hemodialysis are combined. You can see here 10 studies look at it. And then when the setting of atrial fibrillation, there's not a whole lot of data. But in the setting of single prevention, like in our particular case, looks like there's a relative risk reduction of decrease in the odds of about 25% that was statistically significant, and that's for major bleeding. And when you're looking at clinically relevant non-major bleeding, minor bleeding, also slightly decreased. But keep in mind, these are observational studies mostly, so biased by indication, confounding, and other things. And then no significant difference in ATEs, but certainly evidence that is somewhat reassuring in that particular setting. So due to her IINRs, due to the high risk of recurrent VTE, low perceived risk of bleeding, the patient was transitioned from warfarin to apixaban 2.5 milligrams POBID for secondary prevention, and she's clinically stable without bleeding or thrombotic complication on follow-up. And maybe we'll stop here and get Suraj's questions, and then we'll conclude.
Yeah, great. Thanks, Mark. There's a really good question that just came up that I was actually wondering how the panel would approach as well. Imagine a slightly different scenario where you have a VTE that was provoked by a tunneled dialysis line, and recognizing that, of course, dialysis and access is essential for the patient's survival, and the line is likely to be permanent. How would that change your decision making around duration of anticoagulation therapy in a dialysis patient?
So I guess Suraj it's catheter-associated upper extremity DVT in the setting of
Yeah,
hemodialysis.
yeah,
But
different
the
thoughts.
central line will be in forever, so you can continue extended duration, or do you feel comfortable at some point stopping? Eric?
Oh, juicy.
I had to ask you because I'm not smart enough to answer that question.
Neither am I. I used to treat these patients long term, but then my understanding of these clots is that, I mean, they tend to occur within weeks of the lines going in. Like that's my understanding, like a vascular injury. And I think if the line's going to remain in place and these patients are high bleeding risk, increasingly I've been treating these patients for limited durations, like 3 to 6 months, and then stopping, assuming that the clot has hopefully recanalized and that the line is working well. I just think it's hard to justify continuing long-term anticoagulation, especially with warfarin, if the annual bleeding risk with warfarin historically is like, I forget the numbers, like 5, 6, 7%. It's really high. Um, uh, for something that's clearly provoked. I think an analogous situation, which is a bit different, is the cancer patient. And I think that's a bit of a different picture in the sense that inherently there's another prothrombotic diathesis for those patients, the cancer, whereas with these patients who are on dialysis treatment, I'm not sure that's the case. So I've favored more limited durations of anticoagulation, 3 to 6 months, and then stopping. I don't know if that's the right answer. I also think if there's been someone who's had recurrent line access related thrombotic complications, I think the idea of using low dose apixaban is attractive in these situations as well. And so that's kind of how I would approach the situation. So I'm not really answering the question.
No, you totally are, and I agree with you. But when you say it makes total sense when you said, if you look at when these complications happen, a majority within 10 days, 90% within 90 days. So if you think this is your highest risk period of recurrence after the CVC line insertion, it makes sense that beyond that, the risk is probably low. And then if you're concerned about bleeding, then I agree, it seems to like maybe tilting the balance that maybe we're not doing too much and maybe looking for more trouble. So I would tend to agree that probably short course is probably reasonable. It's not like there's an ongoing hypercoagulable state that is progressing the setting of end stage cancer, for example. These are not, and then the balance with the bleeding needs to be considered. Any other comments or thoughts from the other panelists?
I'm glad that Eric was put on the spot first. That's my main comment.
I
Thanks,
get to
Eric.
pick. Exactly. I just do the easy questions. Suraj, is there anything else, or should we close because we're 2 minutes to the end of
Yeah,
our?
I think we've answered the other questions in the chat, but please feel free to ask more questions. We'll stay online for a little bit to answer them in the chat. But I think, Mark, we can kind of close out the session. It's almost 8:15. Um, I'll just basically say thank you, Mark, for being such an excellent chair for the session, and to all our panelists. Really, it's a really lively and rich discussion. And if there are some residual questions, like we said, we can answer them in the chat. That QR code on the slide there is an evaluation. Please do fill it out. We take your feedback really seriously when planning these activities, and hopefully, if there's some areas we can improve, we can address those the next time around. The link to the evaluation is also in the chat there that David just posted a message. And Mark, maybe you could speak a little bit about Thrombosis Canada and donations to the foundation.
Absolutely. And then thanks to you, Siraj and Deborah, for typing furiously in the chat and trying to answer all the questions. It's been much appreciated. And again, thank you to Andrea, Tyler, Erica, Eric. The panelists didn't know the questions. I admire your courage to just show up and provide your insight. I learned a lot. I hope you learned too. And discussing these hard cases are always very valuable when you're stuck with a particular patient. Knowing Andrea does this in Windsor, or Tyler in BC, or Erica in Halifax, and Eric in Toronto makes me feel more comfortable about my management for these patients. So thank you very much. And then if you could please, if you enjoyed the webinar today, please consider donating to Thrombosis Canada. We're a charitable organization. We need your support to continue doing these webinars and provided the resources. So it'd be much appreciated. We thank you for your time today, and thank you for attending the webinar.